right, so our second group of AV blocks, we'll talk about our second degree blocks. Within second degree blocks, we have three separate rhythms that we're going to look at. So a second degree block type 1, a second degree block type 2, and then a second degree 2 to 1 conduction. So in that one, it means we have 2 P waves for every QRS complexes. They also have every 3 P waves is a QRS complex, making it a 3 to 1. So look at our second degree AV block. When some, but not all, atrial impulses are blocked from reaching the ventricles, the second degree AV block results. Because SA node generates impulses in a normal manner, P waves occur regularly across the rhythm strip. Not every P wave will be followed by a QRS complex. So it goes back to it's all about the P waves, it's all about the PRI. So do you have a P wave or the upright? Do you have one P wave for every QRS? And if not, then that makes the rhythm irregular. And if we don't have one P wave for every QRS, then what's causing it? Or do we not have a QRS for every P wave, should say? So, but there's nothing wrong with the sinus mechanism there. So there's nothing wrong with SA node. The problem is occurring at the AV node or AV junction. So the sinus is still depolarizing the atria. The impulse goes to the AV node. Sometimes the AV node is listening, sometimes it's not, and it sends the impulse occasionally. It may send it this time, but not next time. It may send it a little bit delayed each time, and then it doesn't send it. So those are all characteristics of a second degree AV block type 1 or type 2, but all these are characteristics of a second degree AV block. So with a second degree AV block, if the impulse is occurring above the bundle of His, so somewhere in the AV node, we're dealing with a type 1. If it's at or below the bundle of His, in this region, we're dealing with a type 2. So now let's look at what does that mean? A type 1 versus type 2. So again, going back to our rhythm interpretation rules. So we're always looking at the rhythm. Is it regular or irregular? What's the rate? Do we have P waves? What's the PRI? And what about the QRSs? So again, usually we'd have one P wave for every QRS. PRIs will 0.20 seconds or less. One P wave for every QRS. PRIs within normal limits. The QRSs are present. So with a second degree AV block, so let's learn these. So with this, the impulses are generated by SA node. Again, nothing's going on differently within the atria. The problem is happening to the AV node. So we have normal depolarization of the atria occurring. Normal electrical pathways in the atria are occurring from the SA node. So the ECG is a P wave with no QRS after it. So we have the P waves, they're upright, they're smooth, they look like sinus P waves. That's not the problem. The problem is at the AV node. So the impulses generated by SA node take longer and longer to conduct through the AV node until finally a sinus impulse is blocked. So what this is saying, so it sends the impulse, SA node sends the impulse, AV node goes on to it, sends it out. SA node, AV node's held on to it a little bit longer and then sends it out. SA node to the AV node holds on to the impulse even longer than the previous times and sends it out. So we have an increasing PRI for each of these. So you may have a PRI that goes from 0.12 seconds, and the next one may be 0.14 seconds, next one may be 0.18, next one may be 0.20, and then we're losing a PRI because we've lost a complex after that. So you would see an increasing in PRI for each time that impulse makes its conduction through the ventricles. So the repetition of the pattern is called a grouped beating. So again, we see an increasing PRI. So, and this is where the terminology in the type 1 is going, going, gone. So going, the PRI is increasing until it's gone. Because if you don't have a completed complex or QRS complex, then you have no PRI. So you have an increasing PRI until it's blocked. Now the repetition pattern may be every 4th beat is dropped, or every 5th beat, or maybe every third beat. So you have to look at that pattern. So the atrial rate is faster than ventricular rate. Why? Because the atrial rate is firing consistently like it should. We have a dropped complex, QRS complex, so therefore the atrial rate is going to be higher than the ventricular rate because we have the dropped complexes. The rhythm itself, the P to P is regular. So if you were to measure this P wave and look at these P waves, if you were to measure the distance between those, the P to P interval is going to be regular. It's going to be the same. Whereas if you try to measure the Q to R interval, notice this kind of increasing because that AV node is holding on to the conduction, the impulse a little bit longer, so it spreads out the QRS complexes. And finally, we just have a missed beat. So that makes the rhythm, overall rhythm for the ventricular side of it, irregular. P waves, note the P waves are upright, smooth, rounded, they're normal sinus P waves. And then with a PR interval, lengthens with each cycle. So again, what I was saying, you may increase 0.12, 0.14, 0.16, 0.18, and then we drop a complex. So notice that PRI here, beginning of the P wave to the beginning of the QRS complex. Notice how it's increased, and then finally we dropped a QRS complex. So again, it's kind of a repeating pattern. And then there will be a drop complex over here. But notice the increase in PRI that is occurring. And then whether QRS complex is present, as long as, do we have a QRS complex, yes or no? Is it wide or narrow? Even if it's wide, maybe due to intraventricular conduction delay. So, secondary AV block, type 1. Normal P waves, rhythm's irregular because of the drop QRS complexes. PRI increases, and it increases until we drop a beat. But look at that PRI length. When you're looking, do you have P waves, yes or no? Do you have one P wave for every QRS? Yes or no? In the case of all these secondary blocks and third degree blocks, no. You do not have one P wave for every QRS complex because you have dropped QRS complexes. The rhythm overall is irregular again because of that. The PRI lengthens. It's not constant. It lengthens or increases for each cardiac cycle until we have a dropped QRS complex. So what causes it? May see an increased parasympathetic tone, ischemic heart disease, effects of some drugs such as digitalis, beta blockers, or verapamil, maybe others, inferior wall MI. So the result of increased parasympathetic stimulation rather than injury to the conduction system from the inferior MI. So these patients are usually asymptomatic. They may just feel like the heart skipped a beat, not necessarily fluttering in the case, but usually asymptomatic. Again, it may just be something we find. If the patient's symptomatic and the rhythm is a result of medications, these substances should be withheld, obviously. If something's hurting you and you don't like it hurting you, then stop that substance. If the heart rate is slow and serious signs and symptoms occur because of the slow rate, consider atropine or temporary pacing. So if that patient is symptomatic, associated with the rhythm, or even is rate-dependent symptomatic, so what is symptomatic, right? So, or does that make them stable or unstable? So, are they having effects due to these slow heart rate? What is their blood pressure? What's their mental status? Pulse oximetry? Are they having any chest pain associated with it? Then we can consider atropine. Because again, there's nothing wrong with the SA node. The SA node is firing fine. So even though we would still increase those PRIs, if we can increase the number of P waves we have, then we can increase the number of QRS complexes we have. We're still going to have those drop complexes, but we can speed it up a little bit to increase heart rate. So if we increase heart rate, increase blood pressure, hopefully. When this rhythm occurs in conjunction with acute MI, observe for increase in AV block. So again, if we suspect an MI, they already have a block, a patient's at higher risk of developing or worsening AV block.